All right. Well, welcome back to Ultrasound Grand Rounds this week. Actually, this year. This is the first Ultrasound Grand Rounds for this academic year. We're pretty excited to be back. So it is, as we record this, the end of August, which means our new interns have been here for about 2 months, and our ultrasound fellow has been with us for about 2 months. I mean, he's been with us for a while because he's one of our former residents, but he's been an ultrasound fellow with us for a couple months. All of them are hitting the ground running and doing amazing, and we're starting to get back into the normal educational routine of our year with ultrasound. And so we're back. We're back with Ultrasound Grand Rounds, and we're pretty excited to bring this year's series to you. So I want to get into today's conversation. We're going to show you 4 cases, 4 teaching points that will help you be better at your ultrasound and level up your game. But today we are back for our first conversation of the academic year. So we've got our new residents fully onboarded now. They've been here for a couple months. We have our ultrasound fellow who is really hitting it hard, doing a great job the beginning of this academic year. And we're going to get started with the formal didactic curriculum, for our Ultrasound Grand Rounds, this slot that we're doing twice a month as we go through the academic year. And so every year, what I like to do as we get started is to start the year and to end the year thinking kind of a big picture thing, right? Thinking broadly, not getting too focused into one niche area of ultrasound to kind of set the stage for the rest of the year and to help us just kind of catch the vision for doing point of care ultrasound and the value and the benefit that has to the patients that we serve. And so today's lecture is going to be entitled A Walk Down Memory Lane, right? And this is, don't read into the title too much. Don't read the tea leaves. It's not me getting sappy in my old age. I'm not signaling anything here other than to say I went back into my archives. I was thinking, what can we talk about here today that would be interesting that hasn't been done yet on this channel, this discussion forum. And so I was looking through my archives and found a number of old studies that I did when I was a fellow or a junior faculty that I thought were really interesting, had some interesting teaching points that we really hadn't shown on this forum yet already. And so I think it will be interesting for you today to hear these things, as it will be interesting for me to share the studies that we've done just a couple years ago, right? It wasn't too long ago, not that old. So a walk down memory lane, right? So that's going to be the topic for today. I got 4 cases, and we'll wrap it up. If you stay all the way to the end, 4 nuggets, 4 teaching points, 4 things that you can take to the bedside next time you go and scan patients or you're working clinically. So let's dive right on in. Case number 1, right? This is a case of facial swelling, and this is one that we actually published, right? This is a case report that we put out. The images are our own, right? Ones that we created, ones that we submitted for the publication. If you want to read the full publication, right, it is here with the QR code that's in the corner. But this is a case of facial swelling, right? And so we see these patients not infrequently in the emergency department. They come in with complaint of jaw pain or face pain, and it's really easy just to say, oh, these are all dental, here's some antibiotics, here's some pain medicines, please leave, go to the dentist. They can pull teeth. I don't do that. I'm the emergency department. And kick them out the door, right? And that's, for a lot of patients with dental pain, there's a little extra compassion sprinkled in there to alleviate some of the suffering that the patient's experiencing. However, for a lot of the patients with dental pain, there's not a lot we can do in the emergency department, and we rely on our dental colleagues, and we try to set them up for success as they take the patients after us. But for this particular patient, right, you are a more astute clinician, right? You're here. You're learning about point of care ultrasound. You want to be better. You want to be the best that you can be in the emergency department. And so you notice that this patient doesn't have, it just doesn't feel like your normal dental pain that you're just going to say, have a nice day, right? You notice that the swelling it's in the face, right? There's a good deal of swelling in the face, but it's actually a little bit more submandibular than you'd otherwise expect, right? And that kind of gets you interested, right? And you look over the buccal space inside the mouth, and it's not ridiculously swollen there. It's not really ridiculously erythematous. The gingiva doesn't look terribly inflamed. And so out of curiosity, you're like, this doesn't seem like the typical, periapical abscess that can just go to dentistry. There seems to be something a little bit more going on in this particular patient, right? And so to brush up a little bit on the anatomy from the Complete Anatomy app, If you take away the skin, take away some of the superficial layers, what we have here is the mandible, right? And thinking about what lives underneath that mandible, the main thing that we're going to see is that submandibular gland. Now, there's going to be a lot of musculature. There's going to be some arteries and nerves. There's even be some lymph nodes that we need to think about in our differential. But the big thing that we can think about that's in the submandibular space that can cause some submandibular swelling, right, is that submandibular gland. And so let's take our ultrasound. Let's look at that particular gland, right? And so in this particular case, we have the gland here, right? We have on the left side of the screen, we see just the 2D echo or 2D version of it. And on the right-hand side of the screen, we threw some color Doppler on. And what we're initially met with is this mid-gray echogenic kind of lobular appearing structure, right? That seems to be right where that submandibular gland is. And if we put the color on, like we show here on the screen, we can see that, while there's a lot of kind of blackish structures in there, a lot of them light up, but one of them doesn't, right? And so we've seen kind of this phenomena before. We've seen this in the context of doing renal studies where we look for hydronephrosis and we see some obstruction in the distal ureter can cause some upstream dilation of that collecting system, right? And then here we say, I wonder if this is something very, very similar, right? We have a duct system that takes the stuff that the submandibular gland makes and dumps it out underneath the tongue inside the mouth. And so normally that ductwork is not terribly well visualized just because it's normally not terribly well distended. But in this situation, it seems to be somewhat distended, right? And if we kind of dive a little bit further back into the anatomy, we can think through the submandibular gland has a duct, right? We can see it kind of traveling there from the submandibular gland all the way to underneath the tongue, right? And this is, if you want to give it's technically called the submandibular duct, but if you want to give it a name, right, the name that's usually been given is called Wharton's duct. And this is going to, take all that material out of the submandibular gland and kind of dump it into the mouth. And so when you see an obstruction, right, when we've seen an obstruction in the past, we tend to try to follow that obstruction to see what's causing it to be obstructed, right? And so in this situation, we followed the submandibular duct or that Wharton's duct from the submandibular gland. And it's pretty easy if you kind of do it in long axis relative to the submandibular space, right? You can follow that underneath the jaw. And lo and behold, as it's about to dump into the mouth, right underneath the tongue, we see a large echogenic structure, right? This oval-shaped echogenic structure with deep shadowing. So we can follow back on some of the principles that we've learned in the past about what stones look like. In the context of previous, discussions, we know that stones can be, or, calcified stones tend to have that hyperechoic, surface structure with that deep, deep shadowing. And this looks very similar to what we've seen in the past. And so this is a submandibular gland stone, right? This patient was having some swelling in that submandibular space from the inflammation that resulted from the submandibular gland's stone, right? And the stones tend to get lodged kind of in this area. So it's a great example of a case of, maybe the same principles that apply that we've used in other contexts for renal studies or gallbladder studies or things like that, but really applying it to a new area of the body that we haven't necessarily talked about significantly in the past, right? Looking for that submandibular duct. And so if we follow the case on out, so this patient got a CT scan to further differentiate things here. We can see on the study, the right-hand image on that CT scan, you can see that enlarged, that large submandibular duct. And then when the patient actually passed the stone, right, we had the patient pass the stone in the emergency department, you can see a large stone-like structure, at the scalpel there for size comparison to show kind of what came out. And so normally these things, when identified, are treated with sialagogues, right, to help kind of promote that salivation. And then to the extent that there's any concern for infection, right, sialoadenitis, then you can add on antibiotics that would cover your oral flora. So that's the first case that I wanted to start off with. I thought it had some interesting, unique application to ultrasound that we hadn't really talked about before, right? But taking, like I said, some of those same principles that we've talked about in other contexts and applied it to a new area of the body, right? So we're going to move on from that case to case number 2. And like I said, we'll get back to some really interesting teaching points on each of these cases at the end. But case number 2 is the case of the mystery of right upper quadrant pain. So this particular patient, we've seen a ton of patients with right upper quadrant pain in the emergency department. I don't remember the specifics of this particular case, right? In terms of what was unique about the presentation. So let's just say, for the sake of this discussion, right, the patient presented with several days of pain in the right upper quadrant. Maybe it radiated the epigastric area. There's probably some nausea and vomiting with that. And the vital signs were otherwise decently normal, right? It's a pretty generic case of, someone who's coming in with that right upper quadrant area tenderness. So right off the bat, what do we need to do? Probably one of the best initial tests for us to look at is an ultrasound, right? They're going to get some labs, right? We'll get like history and exam, right? But then when we get to, the workup portion, they're going to get CBC, BMP, LFTs, lipase, right? The standard right upper quadrant, stuff. And then we're going to go to an ultrasound. So we're going to do a bedside ultrasound and see what we can find. And so starting off here, we have the right upper quadrant, the sagittal oriented, or the ultrasound image oriented sagittally with respect to the gallbladder, right? I guess that's what I was trying to say. So the long axis of the gallbladder. And a couple things jump out, right? It's where it needs to be. It's right underneath the liver. It seems to be a little bit big. We'll get some dimensions on that later, right? But we can see basically the anechoic blind-ended pouch. That's the gallbladder. But there's something echogenic in it with a very distinct line, right? Kind of a gravity-dependent line of some debris, some echogenic material inside that gallbladder, right? And if we switch to the transverse orientation, right, transverse relative to the gallbladder, we can get pretty much the same thing. It looks a little bit big. We see that fluid-filled gallbladder with the echogenic material kind of layering out in the gravity-dependent area. So that's kind of interesting, right? So what we're left with right now is basically a gallbladder full of sludge, right? Now, does this explain the right upper quadrant pain? I think we need to keep looking to see what else is going on in here. And so, like I promised, we're going to have some dimensions. In the transverse dimension, it's a little bit over 4 centimeters. So technically, it's just a touch distended, right? And the gallbladder wall thickness is just a touch over 3 millimeters. And so it's right on the border of what we would consider to be normal. And if you think back, we've done other videos on the gallbladder before. I'd encourage you to go back and look at the normal and the abnormal gallbladder videos that we did, I think it was last year. And we talked about the normal findings for a gallbladder, right? Transverse diameter less than 4, wall thickness less than 3, and then the findings that would suggest cholecystitis. Understanding that cholecystitis is a clinical diagnosis with sonographic features, right? But the cholecystitis findings would be things to the effect of, is the gallbladder distended, right? Is the wall thickened? Is there pericholecystic fluid, or that inflammatory fluid around the gallbladder? And then does it hurt when you smash on the thing, right? Do you have a sonographic Murphy's sign? And those are going to be suggestive of the gallbladder being the problem, right? And cholecystitis being high on the list of concerns, right? And so, let's say the patient has multiple of those. We just haven't seen the stones yet, right? So the next thing we want to do is try to find the common bile duct. Unfortunately for this patient, they highlighted it for us, right? When you're looking at radiology images, there's one thing that you can find oftentimes in abnormals, and that's the pathognomonic arrow sign, right? So the radiologist takes a look at it and they put an arrow right at what's wrong, right? And when you open up the study and you find the arrow, you're like, there must be something there. So that's a radiologist doing it for you. It's actually really, really nice when the patient does it for you. And so in this one, we have, for whatever reason, the vascular structure has a Doppler appearance with an arrow pointing right at that common bile duct. But to the extent that that doesn't happen normally, the CBD is normally found just anterior to the portal vein as you turn your probe a little bit towards that 10 o'clock position. And it tends to elongate out into this train track appearance that does not fill with Doppler when you throw the Doppler on. In a normal, just for context, is less than 6 to 7 millimeters in diameter for a normal person. And then you can include an extra millimeter per decade of life after you hit about 70. So if you're 80, you can tolerate up to 8 millimeters. If you're 90, you can tolerate up to 9 millimeters, things to that effect. But for the most part, the common bile duct diameter should be 6 to 7 millimeters or less. In this context, it is definitely pushing that range. I think it's not listed on here, but I think it was about 7 millimeters was the CBD diameter. So again, it's a little bit distended. So what we're left with so far is a distended gallbladder with some echogenic material in it, no stones visualized yet, and a distended common bile duct. If we look up towards the liver, right, we can notice, got to get on There we go. So we look up to the liver and we notice that the liver just seems to be a little bit congested. Just there's a little bit more veiny than you normally expect. There's more black stripes in the liver than if you looked at a normal one. So on the left, you can see kind of that confluence of the hepatic veins and the biliary system. And on the right, you can see a little bit more of it. And what I wanted to show you is that when you have intrahepatic biliary dilatation, it just looks congested. And oftentimes, and if you look at the left upper or the upper one, you'll see that a lot of these ductworks run parallel to each other. Actually, you can see a little bit in that left side. And then if you look in the upper one towards the beginning of the clip, you'll see that there's some parallel ductwork that represents the vascular plus the biliary ductwork. And this is just an example of intrahepatic biliary dilatation. So again, bringing it back to the patient, we have symptomatic right upper quadrant with distended gallbladder, distended CBD, and now distended intrahepatic biliary system. So we have to answer ourselves the question, where's the obstruction, right? There's an obstruction somewhere. We knew that from even the previous case, right? If something's dilated, it's not normally dilated. Why is it dilated? Well, probably something's there blocking it off. And so, we need to go hunting for that obstruction. So let's go back to that gallbladder, right? We didn't see it on the first ones, at least initially, largely because this stone, right, was buried deep into the gallbladder neck. So one thing that you have to be really careful for, and I've seen this a number of times over the years, I've showed this to people a number of times over the years, is you can scan a gallbladder and the gallbladder itself looks decently normal. That being said, the story is highly concerning for biliary etiology. And when you really, really, really focus in and scrutinize that neck, you can find a single isolated stone wedged in that neck. And if it's down there, it's oftentimes really, really hard to see, or can be challenging to see, because it gets lost in the other hyperechoic spaces nearby of the loops of bowel, and the shadow can kind of get lost a little bit. And so I thought this was a really interesting case because it teaches a number of different things, right? But mostly look for that neck, or look down at that neck. And in this situation, if we want to extend that a little bit further, asking the question, well, why is there dilation? That's another question that we need to answer for this particular patient, right? And there's a couple differentials that you can consider when you have a stone in dilated everything. One of those is something called Marizzi's syndrome. And I can't confirm that this is a case of Marizzi's syndrome, although it's highly concerning. But Marizzi's syndrome is essentially a stone, usually in the cystic duct, it can be in the neck, that causes extrinsic compression of the rest of the biliary tree, right? And so it's oftentimes associated with this intrahepatic biliary dilatation. It's oftentimes associated with jaundice and then fever and other things. And so it's on the consideration list, but it also could be that this is just a harbinger of another stone somewhere else that we're not visualizing further down the tree. And there's a need to evaluate that biliary tree all the way down to the sphincter of Oddi as it's kind of trying to dump its stuff into the intestines. And so if you remember back from last year, we had a conversation with Dr. L. Hayek about how a surgeon approaches the right upper quadrant in evaluating these patients. And if you want to learn more about that, head back to that video from last year where we had a fascinating talk about how Dr. L. Hayek evaluates with ultrasound that biliary tree all the way down to the sphincter to evaluate for this potential hidden stone. So interesting number two case, right? Switching gears a little bit, the third case is called the case of containing the mess, right? And you'll see why in just a minute. So you're working a busy shift in the emergency department. EMS brings you in a patient that you put in one of your critical rooms because the patient is hypotensive. Let's say 70/40. Again, I don't remember the exact blood pressure, but let's say it's something low. Right? And as you walk in the room and say, do your typical, oral boards. Hi, what's going on? What do I see? What do I hear? Right? You walk in and you see a patient who is being transferred from the cot to the bed, who looks about as pale as the wall. Right? And you know that most people aren't like the wall color, right? Most people, look a different color than the wall. And when you see that a patient is pale, then, there's something usually concerning going on, right? And so, you start thinking through, okay, well, patient's got this hypotension, right? It's got this pallor. What could be causing this? And what do I need to do to get started, right? And a good first initial approach would be a cardiac exam. And we're not going to go there, right? This is not a cardiac case. But if you did a cardiac fast, that would be a good first right thing to do to assess kind of what is the vascular status, what is essentially the pump, tank, and pipes, right? What's the functional status of all those three, right? The next thing that would be helpful to do is to transition to a fast exam, right? To look and see if there's free fluid, because you're saying they're pale, right? Is there free fluid associated with this patient suggesting that the patient's bleeding, right? And so let's do that. Let's look at the fast exam. So here's the right upper quadrant for this medical fast. And what we see is the liver. We can see a little bit of the kidney coming in there, the Morrison's pouch area, and it looks pretty clean. There's really nothing there, right? And so, in terms of massive hemoperitoneum, I'm not seeing anything that would kind of steer me in that direction just yet. Now, multiple other windows to go. And so we have, more things to look at. And it's a case that I'm presenting. So there's got to be something interesting in here. So next side is the left upper quadrant. And we can start there and we see kind of around the spleen, there's not much. In the perisplenic area, there's not much. But then we get to this large fluid collection right here. You can see this echogenic or poorly echogenic, or I should say anechoic, with these echogenic speckles that seem to be swirling around. It seems to be acting or behaving like a fluid. And that's kind of interesting in this area. And what's even more interesting is it doesn't appear to be acting like free fluid. It seems to be reasonably contained fluid. And so the question then is, well, what is causing a large amount of contained fluid in the left upper quadrant? And if we remind ourselves of the anatomy of the left upper quadrant, we have kind of that left lobe of the liver, here on the left side, and you can see the spleen kind of wrapping around the back, the kidney back there. And in between the two is this large structure. It's a stomach, right? And so the stomach, is we talk about in the fast exam talks about how it can be a pitfall. When you see fluid in the stomach, you can, artificially think that there's fluid in the left upper quadrant. Here's an example. We're actually thinking about it backwards, right? We're looking for fluid in the left upper quadrant, and we're not seeing it because we're seeing it contained inside the patient's stomach, right? And so if we come back to this case, we can see, again, that swirling echogenic material inside the stomach. There's another view here. You can see that bowel gas kind of at the least gravity dependent area of the stomach, shadowing down over part of it, but you can definitely tell that there's fluid inside that stomach, right? And so I guess this begs the question, with the patient who's hypotensive, with the patient who's fail, with the patient who's got lots of swirling fluid in the stomach, what in the world is going on, right? What's causing this? Is this ultrasound image even important, right? And if we think about a differential diagnosis for what's causing this massively distended fluid or stomach, it could be that the patient just ate, right? Maybe they weren't feeling good. They tried to pound a whole bunch of food and then they felt even worse and came in. It's possible. Or the other problem here, or possibility, given kind of what we're seeing, is the patient could be having a massive upper GI bleed, right? And that's where the patient we ended up diagnosing the patient with. The patient was having a GI bleed. And if I remember correctly, I think the story was some preceding hematemesis. So we kind of knew going into this what we were looking for, and happened to confirm it with our ultrasound. But what was interesting is how much we found, right? We didn't expect to see that massively distended stomach as we were looking. And so this kind of begs the question, what do we do next, right? So, great, you did an ultrasound, you confirmed that the patient has a GI bleed. I could have told you that because of the whole maroon stuff all down his shirt. Now what do you do, right? And so if you think about the context of the management of a GI bleed, it's going to be number one, resuscitate, right? So you're going to start the medical resuscitation. You're going to get the patient on antibiotics. You're going to get them on, some triatide. You're going to, give them blood if you need to resuscitate this patient. It doesn't help if the patient doesn't do well, right? If the patient crumps, everything else is kind of window dressing. You have to resuscitate the patient. But then after you start getting the patient stabilized, the next question is, okay, now what do I need to do, right? They have a massive GI bleed. Presumed they have, okay, perhaps they have a little bit of an ulcerative bleed, but it seems unlikely that produced that much blood. I'm suspicious that this patient has a variceal bleed that's just pouring blood into the stomach, right? So this patient needs to have something, right, to identify what's the source of blood and then to stop that thing, right? Like I said, all bleeding stops eventually, right? This is the type of bleeding that we want to make it stop as opposed to let it stop. And so the patient needs an upper endoscopy. I don't do that. The GI folks do that. So I need to get them on the phone and get them to convince them to come in and do this urgent scope or emergent scope, right? When we ask them to come in, they'll say, fine, I'm going to come in. I'll get this guy scoped. Let's put him up in the MICU because that's the easiest place, at least at our institution, to make it all happen. But we need you to do something first, right? We need you to intubate this patient because, when you scope the patient, we want to have a controlled airway in this context in case anything goes sideways so that we don't lose an airway while we're trying to, we don't lose A essentially while we're trying to save C. Right. And so now we have a new set of priorities that we need to work on. We need to do an airway for this patient. But what are we going to do when we do this airway? Well, number one, we're going to lay them flat. And number two, we're going to give them RSI meds to basically knock them out so that we can get this airway in. Both of those things will increase the risk of aspiration for this patient, and particularly in this patient, because we know there's a massively distended stomach. And so what this ultrasound helps us do is, number one, to know what's going on, right? What our risks are, and then help us mitigate those risks so we can resuscitate this patient in the safest possible manner, right? And so that brings us to what we talked about, I think it was 2 years ago now, or about a year and a half ago, looking at gastric ultrasound, particularly prior to intubation, right? And I know the anesthesiologists do this a lot up in the OR for their elective cases, as it can help understand what the gastric dynamics are, particularly in a patient with your, gastric emptying, delaying medications, right? But in our context, oftentimes the emergent situation dictates that we just get the airway done quick, sooner rather than later. But in this situation, it's actually a really good case to look at that gastric outlet and see, is this patient in a situation where I can safely lay them back and do RSI, or do I need to do a few things first before I can make it even safer to do this? It's semi-urgent, semi-elective intubation. And so we looked in that lecture about the cross-sectional area of the gastric, antrum over the aorta. And depending on what size that is relative to the patient's size, that can predict how full the stomach is. And so in this situation, it's not hard to see. It's super duper full, right? That gastric antral cross-sectional area is very, very large. And this would suggest that we need to do some things to decrease the volume of the gastric contents before we intubate the patient. So, and G-tube, trying to get some of that stuff out, and then we can throw the airway in this patient so we can do it a lot more safely. So interesting case where the ultrasound didn't necessarily make the diagnosis for us, but significantly informed some of the management steps that we had that we went through as we took care of this patient. Right? And that brings us to case number 4. Right, so this is going to be an interesting case as we wrap things up, and then we're going to talk about a few specific teaching pearls from each of these cases. So the case of not so fast. So this is a pediatric fast, right? This is a case that came in category or as a trauma patient who fell, right? And I believe the patient had a head injury. And so one of the things that was requested by the trauma team is that we perform a fast exam. And so here's the basic windows: the right upper quadrant window, the left upper quadrant window, the pelvic window, and the cardiac window. And I apologize, they're not video windows right there's still windows right now, but we'll show some videos here in just a minute. And for all intents and purposes, from the fast exam perspective, from the looking for free fluid perspective, it's pretty normal, right? There's no free fluid in this patient's abdomen that we can detect. And so the trauma team was happy, right? They're happy that they could find find that information and incorporate that in the care of their patient. However, there is one feature about this exam that's a little bit concerning. Right? And I want to direct your attention to the right upper quadrant, specifically at that kidney. And we're going to go to a live view here. So here is a video of that kidney in the liver-kidney interface. And we see what looks pretty normal to us. It can tell you, look at the architecture of the kidney itself, right? And so if you look at the inferior pole, it seems to have that hypoechoic cortical architecture. But if you look at the superior pole, it seems to just kind of have this, little lighter and smudgier architecture, if you for lack of a medical term, right? And we can even look at another window here where we can see just kind of that big globular smudgy architecture, that superior pole of the kidney. And the other interesting thing and maybe this is kind of giving it away a little bit, is that lobe of the liver, that back lobe of the liver, just seems to be a little bit generous, right? Just seems to be a little bit bigger than we normally tend to associate with, a typical pediatric, fast exam or pediatric liver. So we dug into that a little bit more. We scanned a little bit more around that area. Here's another example, looking of that kidney and that liver interface. And what we, again, tend to see is just that abnormal kidney architecture and that large, lobulated mass-like thing in the liver. Right. Scanning a little bit further up in the liver, now we see some cystic components to that. I think it's probably safe to say now, mass in the liver. Right? You can see the anechoic collections inside the liver where that ought not to be, right? The liver should be pretty heterogeneous. It should be pretty smooth architecture. The only thing anechoic inside the liver should be the vasculature, or I guess in the case that we talked about in the earlier, the biliary tree. But again, that's not normally well seen in a patient who's not obstructed. And so having this irregular cystic stuff inside a mass in the liver is highly concerning for some right upper quadrant mass. And so that opens up a differential diagnosis, right? And so this isn't exhaustive by any stretch of the imagination, but just a few common things in the pediatric population that can cause these symptoms, right? Or these findings would be some form of, like, if you're looking from the liver perspective, like a hepatoblastoma, hepatocellular carcinoma, a hepatic hamartoma, or hemangioendothelioma, right? Those are all the liver things. If you're heading over towards the kidney side, because the kidney is right there, you're talking about like a Wilms tumor or adrenal neuroblastoma. And then you always have to think in kids, like, could this be some, crazy lymphoma or something like that, right? And so again, for the adult side, if you want more information about interesting liver findings, check out Sandy's lecture from last year about the liver and the spleen findings. She had a pair of lectures. But in this context, this is a pediatric patient with a mass in the kidney and the liver area, right? And so ultimately, the patient was diagnosed with CT scan, because we were like, hey, this is weird. You need to get a CT scan. The patient was diagnosed with a Wilms tumor, right, as the ultimate answer for what's causing all of this. So these 4 cases bring us to a couple different teaching points, or 4 teaching points, because we could talk about these and say, hey, that's kind of cool. We'll share some war stories about, what we've scanned in the emergency department. And that would be an interesting lecture, seeing some things, but it really doesn't benefit you at all if I just share some of the things I've seen. So in order to provide benefit, to give you something to take to the bedside, some concepts, some techniques or theory or practice, I want to give you 4 specific teaching points that these studies illustrate so that we can improve the care of patients that come in with things that would be perhaps similar, right? So for case number 1, right, we talked about the case of the sialolithiasis or sialoadenitis, right? The thing to remember here is think outside the box, right? Once you know the principle, right? Once you know what does obstruction do, what does it look like, we can start beginning to apply this in a number of different places, okay? So I've done this in the course of my career in the submandibular gland. We've done it in the parotid gland. We obviously talked about the kidneys. We talked about the gallbladder. And then the next question is, well, what is causing that obstruction, right? And so sometimes it's intrinsic things, right? Sometimes it's stones. Sometimes it's extrinsic things. And so I remember one case that I had over the year, or a few years ago, and I don't have the picture here. I'd have to go find it. But the patient came in with unilateral hydronephrosis, right? I thought that was interesting. And typically we say, oh, it's a stone, have a nice day. But then when we scanned in the pelvis, right, did the bladder view, we found that the patient had a large ovarian cyst that was extrinsically compressing the ureter, causing the upstream hydronephrosis. So again, it's taking that principle that what does something obstructed look like? What causes obstruction? Things pressing from the inside, things pressing from the outside. And now let's use our knowledge of the anatomy, right? Let's use our knowledge of this patient and how to use this ultrasound machine to really work that puzzle and follow that tree that obstructive tree down to its roots and identify what's causing the obstruction. So that's principle number 1. Think outside the box. Use the principles that to work the problem to find the solution, for the problem that you have, right? Case number 2, right, was the case of the hidden gallstone. And so the teaching point here is be careful with that gallbladder neck, right? Things can hide easily in that gallbladder neck. And so when you see again, dilation, where you ought not to see dilation, you have to ask yourself the question, well, what is causing it? And then once you've asked that question, then you have to come up with a plan for how you're going to identify it. And sometimes it's, again, looking further with your ultrasound. Sometimes it's getting another study, as we saw, throughout the cases today. But when you find that obstruction, you have to go chasing that and try to answer the question of what's causing it. And when you're looking at the gallbladder particularly, always, always, always scrutinize very carefully that gallbladder neck, because stones really like to hide there, and they're camouflaged with all those loops of bowel that are going to be, adjacent and in that close proximity. So that's case number 2. Case number 3, remember that was the case of containing the mess, right? The GI bleed, the gastric antral size. And so the teaching point here is that the problem is sometimes not free fluid. It's actually contained fluid, right? It's fluid where you don't expect to see it. And then once you find that, in the case of the gastric ultrasound, consider doing this additional step before you intubate. Not saying you have to do it every time, but there may be certain situations where doing a gastric ultrasound before you intubate will save yourself a whole bunch of heartache. Than if you hadn't. I remember one case years ago, right? Very, very similar case, who had an upper GI bleed. And this is long before I even thought to do gastric ultrasound, and we were going to intubate the patient, and the expected poor outcome happened, right? You start intubating the patient, and blood just starts pouring out. And I think if he ended up getting the tube, I want to remember right, or remember the positive of it. But again, it makes for a very, very bloody mess if you don't evacuate that stomach prior to doing the intubation, as we did in the case of this particular patient, right? And so again, remember, increasing cross-sectional area of that stomach increases or suggests an increased gastric volume and increased risk of aspiration. So scan before you go, right? In case number 4, let's see if I can get a switch. There we go. Was the case of the Wilms tumor, right? So the case of the FAST exam that turned into a Wilms tumor. And there we go. The teaching point here is mind the corner clues, right? And this is something that was taught to me way back when I was doing my fellowship. Sorry about the slides. The computer decided to start acting up a little bit. Anyway, so mind the corner clues. This was taught to me early on in my fellowship, that you're looking, oftentimes in ultrasound, we're looking for one specific thing, right? We're looking for, the free fluid in the FAST exam, or we're looking for, the gallstones in the gallbladder. And when we focus on that, we tend to forget about or miss the things that are around that, those additional things. And so in this situation, we saw the patient with the FAST exam, right? The FAST exam was negative, but then when we went back to look at the kidney itself, the kidney looked abnormal, right? There's something that was kind of in the corner of our eye, caught our attention, and caused us to work that up a little bit further. And so there have been a number of cases, this being one of them over the course of the years that I've scanned, where something's off, right? And as you scan to that area, then you find, the heart of the problem that's going on with this patient. So again, mind the corner clues. And when you see something that doesn't make sense, pursue it further, right? And if that's something that you can do, great, do it. If not, if you need to tap out and say, hey, I need some other form of imaging besides my ultrasound, then there's perfect justification for getting that additional imaging to help further characterize the things that you find, so you can really improve the care of the patient that you're taking care of. So I hope this helps. 4 cases, 4 teaching points that sets us up to take things to the bedside and really improve the care of the patients that we have, improve our ultrasound skills when we're there. Moving forward, we're going to talk a little bit about cardiac ultrasound next time, in 2 weeks when we're back together, and then we'll kind of continue further out throughout the rest of the year. So I hope these 4 cases, these 4 teaching points were helpful for you as you try to level up your ultrasound game at the bedside. If so, hit that subscribe button down below, hit that notification bell so you can be notified every time we put out some new content. Head on over to metrohealth.org/POCUS to learn more about our program. And if you have any thoughts or comments, leave those in the description or in the comments below. Until next time, have a great week. Happy scanning. Have a good day, guys. Bye.